special populations, difficult to discuss, actually, here. Lots of different meanings for special. Special offers, special assignments, special K, midnight special, special forces, 38 special, special sessions, special prosecutors. And then there's this special group here looking very unhappy. Silicon Valley CEOs sitting in the White House. Special looks on the faces of the CEOs here. That was in the Times yesterday. Okay, so our standard typical special populations, the ones that we've been thinking about in the past, are patients with hematologic diseases, hemophiliacs, and thalassaemics. Patients with psychiatric diseases, patients who have excessive alcohol consumption. There's always a debate about what's excessive. Hep C in patients with renal disease, and Hep C in patients with HIV. So we've got lots of new prospects coming, or this year and next, that'll take care of our naives, our compensated cirrhotics, our decompensated cirrhotics. Geno3, which has been a problem up until now, CKD and DAA failures. So in decompensated cirrhosis, these are the guidelines, ASLD, EASL, and ILTS. Mostly, actually, I think the main thing is in decompensated cirrhosis, you have to remember this, actually, no protease inhibitors. Remember, because all protease inhibitors, and it's a class effect, are metabolized in the liver, so the levels will go up really high, and they get concentrated in the liver, which is good in child's A cirrhosis, but actually not so good in child's B and C cirrhosis that can cause liver toxicity. So mostly you're limited to a nuke. Sofosbuvir is the only one licensed so far, and an NS5A agent. And then, of course, there's always this debate about when to treat. Is there a point of no return? Should we not be treating above a certain MELD score? I think that's probably a very local phenomenon. It depends on where you are and what you're transplanting at in terms of your local MELD scores. In New York, we're transplanting at 35, 38. So we're treating pretty much right up until that point. In places like Indiana, they're transplanting in the 20s. So a patient with a MELD score of 20 would probably not get treated until after they get their new liver. So it's all kind of local, and it's actually pretty unfair, to be perfectly honest, to the patients. Okay, so there's been a bunch of presentations at EASL just recently about GP, the glucapavir-pabrentasvir combination coming from AbbVie in genotype 3. So we're having really good numbers here, 95, 97, 95. It all looks actually really good. Actually, soft DAC looks really good here too. I don't know what they did to make soft DAC look so good in this study, but GP looks really excellent here, just a protease and a NS5A. And then looking at 8 or 12 weeks for genotype 3 here. Oh, actually, sorry, this is genotypes 1 through 6, pan-genotypic agent. Also with GP, 8 and 12 weeks, the numbers are actually almost 100% all the way across. And for G3, it's 97 and 98, so it's very actually promising here. Even 8 weeks for Geno 3, naive patients look really spectacular. Now, Graham Foster presented this one. This is the Merck proxy study for their triple combination with their own nuke, which is coming. That study is actually the Geno 3 study is already going in Europe. Some of you may be participating in that study. Really, I don't know if you are doing that one or not yet. It's the Merck triple. Grazobovier is part of it. Actually, Albosphere has been replaced by Ruzosphere, and Sofosbuvir has been replaced by Uprafosbuvir, which is the Merck nuke, formerly of Idenix. So at any rate, this is the proxy study, and it actually looks good, both 8 weeks and 12 weeks here for genotype 3, compensated cirrhosis. Remember, because we have a protease inhibitor involved here. At the moment, 2016 EASL guidelines for interferon-free treatment options in CKD, stage 4 and stage 5. Stage 5 is dialysis, stage 4 is just pre-dialysis, are actually fairly limited to green lights anyway with Albosphere and Grazobovier regimens, although you can use soft-vel with caution. I think that's what they say. Soft should be used with caution because no dose recommendation can be given. However, there's actually gathering data about sofosbuvir in renal disease. It's coming in now. In the past, it wasn't studied below GFR of 30, but now it looks like it is. So this is a study of using sofosbuvir in end-stage renal disease. 45 patients here with 100% SVR. Only 3 of the 45 patients were not on dialysis. They were stage 4. No hepatic decompensation, no dose adjustments. AE profile were similar to those in the general Hep C population. So maybe all of our worries about using sofosbuvir in renal disease may have been overdone. So this is Paul Kuo. Looked at this also, actually, and no adverse renal side effects here in patients with mild to moderate renal dysfunction treated with sofosbuvir. Real-world data, baseline GFR is less than 60 in patients in Hawaii, and actually no significant difference when GFR was calculated by any of the GFR equations. So looks like sofosbuvir did not do any damage to the kidney, even when there is low GFRs. And this is changes in renal function with Hep C cirrhotics using sofosbuvir. This was something that we had worried about before in the past, and particularly in people with lower GFRs to begin with. And it looks like there was no difference in GFR between baseline and end of treatment, so no significant changes in creatinine or GFR here using cystatin C, creatinine, etc. And then finally, Zubair Younasi looked at Albosphere Grazobovier in patients with chronic renal disease in the real-world experience from the TRIO network. This combo is supposed to be safe in renal disease because it's pretty much excreted 100% by the liver. Remember, it's a protease-containing regimen, and actually it looked really good. CKD stage 1 through 5, the SVR rates were actually excellent all the way through, and 7% of them got ribavirin without any major issues. So it looks like CKD is no longer a special population, even with using sofosbuvir. Here's the Expedition 4 study, GP, looking at severe CKD, 98% SVR rates, and there were no drug-related AEs, and only anemia in 5 patients. So it looks like we're actually in really good shape with CKD. So I think we can check that one off the special populations list. CKD is no longer a special population. Okay, however, there are a few other things to talk about, okay? But there are some new special populations that we have been discussing in this meeting somewhere along the way. People who inject IV drugs, the under 30 age group, particularly in the US, acute Hep C and HIV, reinfections, pregnant women, and the new pediatric infections resulting from those pregnant women. So patients often in the US are screened by their insurance companies, whether it's Medicaid or other private insurance companies, and so they demand a urine toxicity test from our patients beforehand. Sometimes we'll tell them to go home and get some urine from their wife or their friends if that's necessary and bring it back. because even the presence of cannabinoids in their urine is enough for them to say, no, you can't be treated for your Hep C, which is really insanity, frankly. Anything they can use to prevent people from getting treated. So it depends on which states actually here. So complete abstinence for 12 months in a few of these states like Louisiana and Illinois. And then no restrictions here in Colorado. And then there's a few others that are in between. So should this be an issue, actually, in terms of reality? So even in people who inject drugs, this was a study from Montefiore in the Bronx, presented at EASL. It's a pretty well done trial called PREVAIL. It was actually a 3-arm study. Control arm, subjects, they just given their Hep C medications just like anybody else would get them. There was a DOT arm, directly observed therapy, where patients would receive observed oral doses by the nursing staff at the same time as they get their methadone. So, and that actually also means that they have to swallow and speak afterwards to make sure they're not keeping it in their mouth. Or weekly administered interferon injections if they were getting those as well. And then there was a group arm where the patients who were getting regular treatment, just like this in the individual arm, would actually come to a group once a week and discuss their Hep C treatment and how important it was to take their medicine and do everything right. So here's the adherence actually was much, much higher in the DOT group, which is actually not shocking, frankly. They did much better. In the other groups, they were around 65%. The group and the individual, the group was slightly higher than the individual adherence. So DOT was way, way better, up in the 75%. But what was really surprising, frankly, is SVR12 was actually in the 90s in all 3 groups. So even in the groups with 65% adherence, they still had a 94% SVR rate. So this Hep C treatment is actually surprisingly successful and surprisingly forgiving if the patients screw it up and don't take all the medicine all at the same time. Actually, the only time, Mark showed our study yesterday, the only time that it's an issue is those patients who failed because of lack of adherence, failed because of lack of delivery of drug. So they usually missed 5 days in a row, whereas most of these patients with poor adherence miss 1 or 2 days, or they go away for the weekend and they forget their pills, but then then they're back again on Monday and they remember and they take their medicine. So it's kind of a different perspective. But so treating people who inject drugs, clearly DOT is good, but DOT actually only had 75% adherence. You're talking about 98% SVR here. So this is very impressive data, actually. So even without DOT, 94. It's actually pretty impressive. So I think we can check PWIDs off as no longer a special population. Now, these slides arrived yesterday, actually, from the CDC. So our timing was good, actually. Better to be lucky than good, I always say. And actually, these are the reported number of acute Hep C cases in the US from 2000 to 2015. This number is actually not going the right way, actually. And people keep saying we're going to be out of business. Marion, we should retire. We'll have no Hep C left to treat in a couple of weeks. Yeah, forget about it, okay? Look at this. There's going to be lots of Hep C around, unfortunately. And the really unfortunate part is the highest numbers are in people who were young, 20 to 29 years of age, actually, and then under 40. So under 40 accounts for about 60% of these new infections here, which is really unfortunate. Actually, overall, the CDC numbers has males higher than females. I'll show you the New York State numbers in a second, actually, which are slightly different. So this is the 2015 report, increases in Hep C infections related to injection drug use, Kentucky, Tennessee, Virginia, and West Virginia here. all these red states. Actually, and these are all non-urban. These are not city dwellers, in the street, using drugs. These are the suburban, urban, non-urban, rural folks who had formerly been addicted to opioids from OxyContin, and then they can't get their OxyContin anymore, so they're getting heroin, which is actually much cheaper to get. So here's what's happening in New York State. New York State has a significant number of Hep C patients, somewhere around 500,000, we think. We think there's about 250,000 in New York City alone, and another 250,000 upstate. So 2005 was a typical baby boomer distribution. By 2012, we started to see something changing here, and then there was a tail of younger people here. But now in 2015, the under 30 group is actually bigger than the baby boomer group. And what's actually more disturbing here in blue are the women here. So 63% of these new infections are in women. Particularly problematic because they're all of childbearing age. I did read, though, for some reason, women who get prescribed opioids, even for injuries, et cetera, are way more likely to become addicted than men to opioids. Here's the acute hepatitis C infection incidence ratio. So here's the CDC states that they talked about here. Indiana, West Virginia, Kentucky, and Tennessee. This is New Mexico. I don't know how they got there. That's Maine, actually. And then there's Massachusetts. So this is what's even more upsetting, is that increased hepatitis C detection and risk for vertical transmission. So this is the number of Kentucky children born with hepatitis C, actually, by PCR, and then confirmed by 1 year later testing by PCR. And this number is rising exponentially here. So it's unclear, what this does to children. We all know that's not going to hurt their liver in the first 17 years of life from the Irish women study, but we really don't know what it's going to do to their brain. Hep C is a flavivirus, like Zika virus. And we know Zika virus has some devastating effects on the fetal brain. So I think this is something that we clearly need to be studied, and something that we're actually discussing is treating Hep C in pregnancy to try to avoid some of this maternal fetal transmission. So this was actually just also published in the Annals of Internal Medicine, June 6th, so that was about 2 weeks ago. Hepatitis C infection among reproductive age women and children in the United States. So Hep C doubled in this group from 15,000 to 31,000. By the way, this is CDC numbers that they pick up from surveillance, which means actually that the actual numbers in the US are usually about 10 times higher than this. So these are just kind of surveillance numbers. So 600,000 pregnant women. In those 3 years, about 0.73% had Hep C. About 0.76% of the children had Hep C. And there was a threefold higher incidence of Hep C in the 2 to 3-year-olds, that is 1.6%, than in the 12 to 13-year-olds, 0.5%. So something's changed dramatically, actually, in the last 10 years, that more and more children are becoming infected with Hep C. 29,000 women with Hep C gave birth to 1,700 infants with Hep C every year. And here's the numbers. So look at this. In the solid line are women aged 15 to 44, and that's actually looks like it's going exponentially. It's going up exponentially. So the Annals conclusions suggest a recent increase in Hep C infection among reproductive age women may inform deliberations regarding a role for routine Hep C screening during pregnancy. We have actually instituted that on our Mount Sinai health system. I know actually Marion said you're doing it at UCSF as well, and we're fighting about it actually in the AASLD. I think you lost the fight, though, you said, Marion. I'd be interested to know actually if the Europeans here are screening for Hep C in pregnancy. Hep B is mandatory, but Hep C, not so much. Bart, okay. Interestingly enough, basically what this says, this is the soft Albosphere package insert. I'm not going to read it. You can look it up. Basically, it says it's class B, pregnancy category B, based on animal studies. It looks like it should be safe in pregnancy. There's actually a study, Gilead-sponsored study of Hep C treatment during pregnancy. It's on clinicaltrials.gov. It's a single center, single arm study at the University of Pittsburgh. They want to treat sometime around 24 weeks of gestation with 12 weeks of soft Albosphere. Most of us think that's excessive. We think probably treating in months 8 and 9 would be enough, 8 weeks in most pregnant women. And actually, this study's been going on for 2 years, and there are no patients enrolled. So far, highly successful. So don't ask about results. Now, this was just presented at EASL a few weeks ago in Amsterdam, and Hep C causes a significant increase in infertility. Obviously, that's not a problem for pregnancy, but it actually causes a lot of comorbidity in pregnancy here too, in terms of pregnancy and fetal outcomes. It's a major issue. So it's probably not a good thing to have while you're pregnant. Probably the best thing to do clearly would be to treat the Hep C before you get pregnant, but clearly that's not happening in a lot of our young women. These are the numbers here. Rates of infertility about 4 times higher, and these are the adverse pregnancy outcomes over here, which are significantly higher in patients with Hep C. So in a real-world analysis, Hep C is associated with increased burden for women of childbearing age in terms of infertility, adverse pregnancy outcomes, stillbirths, gestational diabetes, and fewer live births without complications. So try to treat your Hep C before you get pregnant. So I think this one we can add to the list. New infections, particularly in women and particularly in pregnant women, is a special population. Acute Hep C, soft Albosphere, we can treat this in our mono-infected patients easily. It's 100%. You saw this data already. And in the co-infected populations here, this is something that's not new anymore, or certainly in Europe, and that is this is the David Wiles data from San Diego, that there's increasing numbers of incident Hep C infections in HIV-positive men who have sex with men. You can treat this also. This is the SWIFT-C study, soft riba for acute Hep C. SVR12, kind of a little disappointing, 59%, 7 relapses. But this is just soft riba. Actually, Jürgen presented this study at CROI, also 6 weeks of therapy for acute Hep C in HIV patients. Also slightly disappointing, SVR rate, 77%, 4 virologic failures, and 2 lost to follow-up. So 6 weeks may not be enough in HIV patients, actually, in terms of treating the acute infection. Universal treatment. In terms of Hep C treatment in an HIV cohort. You saw this slide already as well. I think Mark showed it yesterday. It's actually very successful, so treating everybody can actually reduce incident Hep C infections here, as you can see, from 11 to 4 per 1,000 just over the course of a few years. So the debate about not treating acute Hep C in MSM should be over at this point. Then there's reinfection. This is the other EASL study about 7-year follow-up of Scandinavian IV drug users. Only about 4% reinfection over 7 years, which is actually pretty good. I think it's worth it to go ahead and treat those folks, not to worry about it, as we discussed. This one was a little surprising, actually, from the C-EDGE study. There were 5 reinfections here in the immediate treatment group, and all 5 were actually well documented to have phylogenetically distinct viral reinfections. So overall, low-risk patients without any obvious risk, about 1% risk of reinfection. People who use drugs, here maybe 4 to 10%, And then HIV-infected men who have sex with men, we're talking 20 to 25% reinfection rate. So that's still an issue. And here's the London data. I think Mark showed you this slide yesterday. So the more reinfections you have, the more reinfections you're likely to get. So the numbers seem to vary around Europe, actually. I think France looks like it's winning here with about 22%. And then there's some lower numbers here. So in the Jürgen's German gecko cohort, actually, shouldn't this be green, or is that like the car insurance gecko that's green? That's why it's purple instead of green. Anyway, so 1% reinfection rate in IV drug users and 11% reinfections in men who have sex with men, which is actually a bit lower than the other reports, which are in the 20%. And this is a meta-analysis from ASLD last year, actually low risk here, IV drug users and prisoners, and then HIV-infected MSM. So overall, these numbers are they're staying in the same range here. So I think the only real special population here is HIV-infected men who have sex with men getting reinfected. This is the failure rates in HIV co-infection here. Male sex was associated with it and higher HCV RNA. But actually, this is different. So this is not the same. This is actually HIV may be a little bit of a special population because it looks like here from the gecko cohort that T cells actually made a difference, and they made a real significant difference in people who were cirrhotic. Lower T cells did make a difference in terms of lower SVR rates. Kind of makes sense if you think about it, but it does look like this is a slightly special population. And of course, there's always drug interactions. I think David's not here anymore, but David's website here is a spectacular place to go for any kind of drug interactions. And that's a little bit special in HIV because there's a way more possibilities of drug interactions. Okay, so to sum it up here, patients with hemophiliac disease is no longer a special population. Psychiatric disease is not a special population, although there are some psychiatric medications that we have to be careful with drug-drug interactions. Actually, so you have to look those up. So look them up on David's website. Patients with excessive alcohol consumption, I think if they have alcoholic hepatitis, we're generally not treating them now, and I don't think that's changed, so we'll call them special, I think for now. Patients with kidney diseases is no longer a special population. Patients with HIV, in terms of chronic Hep C infection with HIV in patients, it's probably not. They're not a special population, just have to watch for DDIs. In terms of acute Hep C and reinfection, then maybe. So people who inject drugs, no longer a special population. Actually, under age 30 age group, I think, well, it may be a special population, actually, because it's new. Acute Hep C, we can go ahead and treat that in the mono-infected. And acute Hep C in the HIV patients. Here, HIV-positive men who have sex with men who get reinfected. We have data, you can do it. I mean, pregnant women are certainly a special population, and the children of those women who get infected are certainly a special population. People who inject drugs, I have that there twice, actually. No, and people who consume alcohol to excess. I think we'll still leave that there. So I'm happy to answer any questions. Actually, we finished reasonably on time. So special populations have changed, I think, a lot. The ones we used to think were special aren't so special anymore, but we've actually discovered some new populations that we might consider to be special. So happy to answer any questions, Bart, if you have any.
Thanks.